All right, let's dive into one of the most common and honestly most debated topics in orthopedics, how we manage distal radius fractures. For this explainer, we're going to do a high-yield review, drawing from the key principles laid out in the latest edition of Campbell's Operative Orthopedics.
Here's our game plan. We'll start by looking at the history and the modern challenges of these fractures. Then we'll walk through a clinical workflow, from the initial assessment and classification to the real art of tailoring treatment for each patient. We'll also take a look at our surgical options and then wrap up with a frank discussion on complications and the key takeaways.
It's pretty amazing to think that over 200 years ago, Abraham Calls laid out what is still the perfect outcome. These words capture the goal we're all still chasing. But as we're about to see, getting there is a whole lot more complicated than it sounds.
And a big part of that complexity is just the sheer volume. Distal radius fractures are everywhere. They make up nearly 20% of all fractures that walk into the emergency department. So yeah, this is one of the most common injuries we treat.
And here's the kicker. Even with more than 1,000 studies out there, there's still no definitive consensus on the single best way to treat them. What that means for us, in the trenches, is that every single case is a multifactorial puzzle we have to solve.
So how do we start solving that puzzle? Well, it all begins with a really rigorous assessment and a crystal clear understanding of the injury pattern. This is the bedrock of our whole approach.
First things first, we have to have a high index of suspicion for injuries that can tag along, especially the Galeazzi fracture dislocation. You've got your radius fracture, sure, but it's combined with the dislocation of the DRUJ. Campbell's calls this the fracture of necessity for ORIF in adults, mainly because it gets missed so often and you just don't see isolated radial shaft fractures that often.
This slide shows it perfectly. On the right, you can clearly see the radial shaft fracture. But the key thing, the thing that makes it a Galeazzi IOT, is the disruption of that distal radial ulnar joint. That's the critical diagnostic feature you absolutely cannot miss.
So what are the radiographic red flags for a DRUJ injury? You're looking for a few key things: a fracture at the base of the ulnar styloid, any widening of that DRUJ space on your AP view, obvious dislocation on a true lateral, or more than 5 millimeters of radial shortening. Any of these should set off alarm bells. Now, to get our thoughts organized, we lean on classification systems. Freichmann, Fernandez, the AO system. And look, we all know their inter-observer reliability can be, let's just say, moderate. But their real value isn't in perfect agreement. It's in giving us a common language to understand the fracture's personality, how comminuted it is, whether it's in the joint, and to start thinking about the challenges ahead.
And that leads us right to the core of modern management, tailoring the treatment to the patient. This isn't about a one-size-fits-all flowchart. It's a careful calculus, balancing the patient's needs with the fracture's demands.
And whether we go with surgery or a cast, these right here are our targets. This is what we call an acceptable reduction. We're shooting for, at a minimum, neutral palmar tilt, less than 5 millimeters of shortening, less than a 2 millimeter step off in the joint, and keeping more than 10 degrees of radial inclination. These numbers are our benchmark for success.
But, of course, hitting those targets isn't always straightforward. We've got a ton of other variables to consider. Things like the patient's age and how active they are, their bone quality, plus the specifics of the fracture itself, and, let's be honest, our own experience and comfort with different techniques. The data on patients over 65 really drives this point home. You can operate, and you'll probably get better-looking x-rays and better grip strength. But, and this is a big but, at 1 year out, studies show no real difference in pain, overall function, or range of motion. For a lot of older, lower-demand patients, a perfect x-ray just doesn't translate to a better functional outcome. So for those patients where surgery is the right call, we have a pretty diverse toolbox of fixation techniques. Let's do a quick tour of our main options.
First up, external fixation. The core idea here is ligamentotaxis. We're using traction to gently pull the fracture fragments back into alignment. By bridging the wrist, it takes the axial load off the fracture, which makes it a really powerful tool, especially for those highly comminuted fractures with a lot of soft tissue damage. Next is the current workhorse, volar locked plating. And it's popular for a good reason. It gives you biomechanically superior fixation, acting as a solid buttress for the volar cortex. And that stability is key because it lets patients start moving their wrist early, which is a huge advantage. But it's not a free lunch. The complication rate is around 15%. The biggest headaches are flexor tendon irritation, tenosynovitis, and even rupture if the hardware is too prominent.
This really drives home how critical it is to get that plate placed just right, making sure it's proximal to the watershed line.
And for the really complex, shattered intra-articular fractures, there's fragment-specific fixation. Think of this as a more modular approach. You're using smaller plates and screws to tackle each piece of the puzzle. The radial styloid here, the dorsal ulnar corner there, and rebuilding the joint one component at a time.
Okay, let's wrap this up by talking about the post-treatment reality, the complications that can pop up, and what decades of experience have really taught us.
According to the literature, malunion is our most frequent complication, showing up in about 17% of cases. This is really our #1 enemy, especially with non-operative treatment, and it's exactly why those radiographic criteria we talked about are so incredibly important.
And it's not just malunion. The potential for other problems is very real. The incidence ranges are pretty wide, but you can see post-traumatic arthritis in up to 65% of cases. Hardware issues can affect up to a quarter of surgical patients, and significant stiffness can hit nearly a third. It's just the sober reality of this injury.
So what's the bottom line? After looking at all the techniques and all the challenges, one thing becomes incredibly clear. The specific brand of plate you use, the specific technique you choose, it's all secondary. The #1 goal, the most critical factor for a good result, is getting, and just as importantly, keeping an anatomic reduction.
Which brings us right back to where we started. With everything we know now about biomechanics, with our advanced plates and screws, and our focus on individualized care, are we finally closing in on that 200-year-old promise from Collies? Or does the sheer complexity of the wrist, and of our patients, mean that a perfect, totally pain-free outcome will always be just a little out of reach? That's the question we're still trying to answer with every patient we treat.